Hello, dear colleagues. This is Tom Thijs. Welcome to our first webinar of the EANS functional section, where it is my job to moderate webinars with world-class experts in the field. And today we will cover brain surgery for pain. And our experts today are Professor Tipu Aziz and Professor André Machado. Both neurosurgeons have made numerous contributions to the field. And we will start with a talk from Professor Aziz, who will discuss neurosurgical procedures for pain, in particular deep brain stimulation. Tipu, please go ahead.
Thanks. Well, first of all, I'd like to thank the EANS for inviting me to talk, albeit virtually, because Brussels is a great town to be if that was where we could be. Although we perform neuromodulation in multiple modalities, today I'll spend a time sharing with you deep brain stimulation for neuropathic pain. Some of my results will have aged, I must admit, because in England, the NHS has withdrawn deep brain stimulation funding for intractable pain. So although we do it, it's unfortunately not for my fellow countrymen. So here we start. Now, what do we define neuropathic pain? It's become a very simplified. It's pain caused by a lesion or disease of the somatosensory system. It's very common. In Europe, 7 to 8% of the general population are affected. 5% are disabled despite medication. And herein is another point that NICE, which advises government on healthcare, have withdrawn almost every medical therapy available to pain clinics. So physicians who are looking after pain can only offer patients antidepressants and cognitive therapy. So the number of percentages we're talking about will rapidly increase. So deep brain stimulation really came about largely through the pioneering work of Don Richardson, who with Heath at the time in Tulane, looked at implanting electrodes made in their own labs and in multiple sites of the brain to look at areas that could alleviate pain. And they were able to do so. So deep brain stimulation came into being as a result of their work, the work of Mazar in France, and a few other places. And therefore, although there are lots of case series, there were no trials of the therapy. And there is this report by Coffey, labeled failed Medtronic trials. And here is my take on it. You see, the first trial was of the Medtronic 3380, which is now withdrawn. It had a huge enrollment, 196 patients, 18 centers. And 46% of patients reported pain relief at 1 year of those who came to follow up. The 3387 trial had a poor enrollment, recruiting only 50 patients across 11 centers. And 16 reported pain relief at 1 year. But across these trials, 70% of patients were lost to follow-up. But if you look at those that did show up, 60% of the patients had relief with the 3380 and 50% with the 3887 at 2 years. And from my point of view, I would have thought it was worthy of FDA approval at that time. But the therapy works, and therefore there have been numerous case series. There's the Richardson's case series going on to more recently Hamani, followed by Oxford, followed more recently by Joachim Krause's publications. And they all show that even at a significant follow-up time, there is a significant number of people who have failed management of their pain that do respond to this treatment. So how do we do it in Oxford? Well, first of all, if a patient is considered appropriate for surgery, they have brain imaging, detailed MRI scan. And at the time of surgery, we fused the MRI scan with the stereotactic CT scan so that we can compute the trajectory. And the first stage for pain is done under local anesthesia. Guided by the frame, we make a 2.5 millimeter twist drill and pass the electrodes as we test the patient. The second stage is done a week later, as we did then, under general anesthesia. And if successful, we implanted a generator and connected it all up, or we took everything out, which was only the deep brain electrode. The effects are quite remarkable. This is a gentleman with amputation pain, and you see the slightest, even breathing on that foot is painful. But when we put our electrodes into his sensory thalamus on table, you could see immediate loss of pain. And he's stable now, nearly 15 years after surgery. Historically, the targets were used were the septal region by Heath, working with Richardson, the caudate nucleus, the PVG or PAG area, the VPL or VPM of the sensory thalamus, and more recently, the anterior cingulate cortex, and also the anterior limb of the internal capsule, as you'll hear from Professor Machado. Now, what are the usual targets and what do we find? If we put electrodes in the periaqueductal gray, just lateral to the third ventricular at the level of the posterior commissure, there is a somatotopy to it in that the feet are represented at the level of the posterior commissure and the face at the level of the inferior colliculus. And if you stimulate accordingly, the targeted area of pain feels a sensation of warmth as if it's wrapped in a warm blanket. And patients quite often report that as quite appealing. If you stimulate in the sensory thalamus, which is somatotopically aligned, again, from an axial point of view, lateral to medial, if you stimulate there in the right anatomical area, you can elicit a sensation of paresthesia, which can be intensified by frequency or voltage. So the patients we looked at were refractory to pain medication for at least 2 years, or they're intolerant of pharmacological interventions. So they were referred to a multidisciplinary team in Oxford, which incorporated pain specialists, neuropsychologists, and the neurosurgeons. And as far as possible, we looked for an organic cause for pain. Neuropsych evaluation excluded psychiatric disorders and any cognitive impairments. And then there's the usual contraindications for any surgery. So looking briefly at our series as it was, we assessed over a 12-year period 197 patients. Of course, public funding was not available for everybody. Having explained surgery, quite a few declined. Several have medical contraindications or psychological contraindications. And 3 turned out on review to be amenable to medication. And 87 actually went on to trial. And because we're testing these patients for a week, a certain number say that they don't get the expected amount of pain relief they want, and therefore they were removed, the electrodes, or they didn't like the sensation. So 76 went on to full implant. And as we'll discuss, quite a few of our cohort were strokes. And time dictated that there were a large number of them got lost to follow-up through further strokes or death. So we had 61 patients with long-term outcome. Assessments were standard, VAS, McGill, quality of life assessments, Euroqual, SF36, health state. And at the short-term outcome, up to 1 year, we could show that across our cohort, and I must say that although these are multiple etiologies of pain, and yet one was able to demonstrate that there was an improvement in pain across the board at 1 year. And if you looked at long-term outcomes, greater than 4 years, efficacy was again sustained in these patients. And you can see that the etiologies are quite varied. There's phantom limb pain. Success rate is quite high, as is brachial plexus. Spinal pathologies, failed surgeries are also quite responsive. Post-stroke pain, we weren't so certain, but we found that nearly 70% reported pain relief to a reasonable level. And there were also face and head pain and various other sorts of pain. But you'll see that the stroke constituted our largest subgroup, which we published some years ago. So what we could say, looking at our experience in that the literature, that DBS is efficient in relieving neuropathic pain of various etiologies. It's effective in the long term, but it does vary between the etiologies and patients. But what about patients in which stimulating the lateral sensory pathway, the thalamus, the PVG, is ineffective? We have to look at other possibilities. And therefore, we decided to go to the anterior cingulate, largely because when we did or do anterior cingulotomies for terminal cancer pain, you get patients entering an interesting state where they feel the pain, but it doesn't bother them. And if you have someone with benign, non-malignant pain, what would happen if you put electrodes there and see what happens? And to save time, I'm not going to go through all this, but the cingulate as a target in humans for pain has a long history. Certainly in Oxford, an open cingulotomy for pain and psychiatric disorder was done by Hugh Cairns as long ago as 1938. So what we decided to do was, given that observation, to target the affective component of chronic pain, and Professor Machado will expand on this much more. So this was our initial study of 16 patients with multiple etiologies, you see, and some of them had previous trials of the other targets. And what was interesting, 9 of them had very widespread pain. So you can see where we put our target. We go 20 millimeters posterior to the anterior tip of the frontal horn. We go a centimeter off midline. And we choose to put the electrodes mostly in the white matter of the cingulate and the tip lying in the corpus callosum. Stimulation parameters are reasonably high, 5 volts, 130 hertz, 450 pulse width. And we've shown across these etiologies that there's an improvement in the VAS, the McGill pain scores, Euroqual, and the health state. So it was looking promising. And we went on to do more, to a total of 24 before we had funding withdrawn. So we don't do it anymore in England, but I do carry it on for patients from abroad and have very good results. And so this is a chapter describing what anterior cingulate stimulation does for him after his post-stroke. He had whole left body pain. So you see, he says he does still feel pain, but he doesn't think about it. It doesn't give him unwanted effects. So he decided it was working, and so we fully implanted him. But being a stroke patient, After several years, he suffered multiple strokes and passed away. So what can we conclude? From 24 patients we did in Oxford up to that period, we got good pain relief and improvement in the quality of life. Patient selection and surgical targeting are important. We'd expect better results with a larger case series and more experience. Some unexpected consequences did happen, in that with longer term stimulation over several years, some of the patients developed intractable seizures. And in such patients, we changed the pacemaker from a standard Medtronic pacemaker to what we called in those days the PC+S. So we could record what stimulation induced seizures. And we're able now to tailor the stimulation pattern so that we can get pain relief without inducing seizure activity. Now, we need to meet the government requirements for a randomized controlled trial. So we have got funding now for a trial of efficacy of pain intervention with DBS neuromodulation, which we abbreviated somewhat clumsily to EPION. We're going to take only one group of patients, neuropathic pain caused by damage to the central nervous system, no peripheral component. Usually describe the pain as burning, sharp, tingling, hot and cold, or stabbing. Described as worse than other types of pain. And people don't realize that after a stroke, about 20% of patients will suffer intractable pain. And of these, 10% are refractory to medical therapy. So it's a very pragmatic trial. Patients are selected for surgery if their indication permits, for the standard neuropsychological physical assessments for deep brain stimulation. What is different for other trials? The assessor of these patients, who's blinded to whether stimulation is on or off, assesses the patient's pain levels at any one time. Patients are randomized to an on or an off on, off on paradigm, or off off, on on paradigm. And this is the sort of design. Patients are screened for appropriateness. They have the usual pre-op, they undergo surgery. In the beginning, all the patients are off, and then randomized to the two groups, as I pointed out, and then they're crossed over. And at the end of the trial, they're all turned on. So, what are the future directions? Well, one, in the UK, we'd like to reestablish funding. We're having to design trials that may not be standard RCTs. We already have rechargeable and directional stimulation. And there's the possibility that even with pain, we could look at closed loop stimulation, looking at neural biomarkers of pain. And we believe that that is possible. And with that, I'd like to keep it brief so everyone has questions and allows other speakers time. And thank you for listening.
Thank you, Professor Aziz. There are probably a lot of questions. I just want to ask the audience to type their questions in the Q&A box. I can already read one of the questions. Do you have experience with cingulotomy and chronic pain?
Yeah, well, not chronic pain, with cancer pain, terminal cancer pain. And I've found that it's very, very effective. And the cingulotomy is one of the safest lesional procedures going. You can make quite big lesions in the cingulate cortex without inducing crippling cognitive side effects. And the effects are quite marvelous. And the thing is, if the pain starts coming back, if the patient's surviving longer, you can repeat and make the lesions bigger.
Would you advise people to do it in non-cancer pain, or would you prefer to
Yes,
stick to the cancer pains?
certainly I would, because if you're looking at a global view, chronic pain due to various forms of injury or strokes is very common. And where I come from, Bangladesh, no one could, in a month of Sundays or for DBS. So it was my ambition pre-COVID to start a cingulotomy service there for benign pain.
I have another question. Yeah, well, you talk about success and how success is defined in studies. And then you discuss this patient who says, well, he still feels the pain, but it doesn't bother him anymore. Do you think that, how would you define success of ACC, stimulation, or cingulotomy for that matter? Well, in a sense, because if you would look at a numeric rating score or a VAS score, it might be that this is not reflecting, or
that's exactly right. And that's what Andres has found, really, that the patients can have improvement in quality of life without a great significant increase in improvement in the VAS scores. Because basically, as I interpret it, what you're taking is an unpleasant sensation, like pain, and somehow converting it to the sensation you'd feel walking on a floor, walk on a carpet. You can feel it, but it doesn't bother you. That's the easiest way to describe it. And one patient described it is like taking morphine without feeling sleepy, because what morphine does, it doesn't take the pain away, but it just doesn't make it bother you anymore.
Professor Machado, do you want to comment on this, or maybe later?
Here's a comment. Professor Aziz is always very, very articulate and content leader in DPS for pain. I would like to hang on to this question and use it as a segue to discuss it in a moment. I'll be able to show a little bit of data to that effect when time comes for me to go through my presentation. But very insightful question on what are we trying to achieve? What's the endpoint? What's the outcome you're trying to get? Let's show a little bit of data, and then we can talk about the concept again.
Okay, perfect. Thank you. Thank you, Professor Aziz. Is there any burning questions right now? Well, we go to Professor Philip De Vlo, who is a direct colleague of mine, and he will present a specific case of post-stroke pain. Philip is a functional neurosurgeon specialized in movement disorders, and his research is mostly focusing on post-stroke pain. So Philip, please go ahead.
Olaf raised his hand in the meantime.
Welcome, Olaf. Maybe you should introduce yourself to the community.
Yes. Hello, good afternoon. Thank you very much, Tipo. I'm Olaf Schijns from Maastricht and chair of the functional section. Thank you very much for being the first lecturer in our first perfectly organized webinar by Tom. I have a first question about the stimulation you did in the cingular region. Did you also see psychiatric problems in those patients? Patients, for example, who changed their character or their behavior after the procedure?
No, we didn't see that either with stimulation or cingulotomy. It's cognitively a very, very safe target. And then if you go back in history, the large series that came out of Boston, they also found it was quite a safe target.
Could we state that cingulotomy or cingulate stimulation, CG24 stimulation, works better for pain than for psychiatric disorders? Or is that a bold statement?
I have no experience with psychiatric disorders.
Professor Machado, maybe later?
So I have never done it for psychiatric disorders either, cingulate ablations, but the data that came from so many years from the Mass General will point to the dual side of lesions for psychiatric disorders. That yes, for disorders of compulsion and OCD, it probably works well at a cost. It carries a cognitive cost, which we need to be aware of.
I see one other question, but I think you already tackled that one. It's were there any seizures? But I think you had some seizures in the ACC population, huh?
Yeah, and that led to our change in the pattern of stimulation.
And then, and what kind of pattern change is that?
Well, what we did originally, having no idea, we offered continuous stimulation. And despite good pain relief, a certain number developed seizures, but wouldn't turn it off because they lose the pain relief. So what we did was change the pacemaker from a standard Medtronic to the Medtronic PC plus S. So we could telemetrically record and stimulate. And we were able to show that if you stimulate, if there a stimulation turns on at a very slow ramp over 8 seconds and turns off at a very slow ramp of 8 seconds, and you give burst stimulation of a continuous stimulation for 3 minutes on and then 3 minutes off. And that pattern of stimulation seems to have eliminated seizures compared to continuous stim.
Well, and then with respect to your trial, you have, well, I think on, off, and then off, on, or something like that. What about washout in DBS for pain? Is that something we have to take into account, or is that something you wouldn't worry about?
Not in the targets that we're going to use in this stroke trial, because we're going to target the lateral pathway, this thalamus and periventricular gray, where if patients lose pain after cessation, it's immediate. The cingulate is very different, but that we haven't incorporated this in this trial, because you can turn a patient on when you externalize someone with cingulate, and nothing happens immediately. They don't report anything immediately. But over 3 or 4 days, they'll report that their perception of pain has changed.
And then you state, well, you have this combination of thalamic and EEG stimulation.
Yeah.
So in your experience, this combination works better than either thalamic or periventricular gray stimulation.
We implant both targets when we did, was that our data didn't show that one was better than the other. So we thought, well, let's implant both. And certainly when we trialed them, there was a certain subgroup of patients that wanted both on. But because we've stopped, we haven't been able to unravel that question.
It's not that you had one group where you turned off one electrode and you used the other.
We did that in the trial period. During the trial, when they were externalized, we trialed them with thalamus. We tried them with periventricular gray. We tried them both together.
And then you implant both, but in theory you have 2 electrodes, so you could trial them later on too. If you say, okay, I was just wondering whether the certain forms of stimulation have a more prolonged effect than others. So,
well, that remains to be found out, because there's a different new patterns of stimulation coming out, particularly burst stimulation, where patients don't feel any paresthesia at all when it's in the spinal cord. We haven't had the chance yet to try it out in deep brain stimulation.
Okay, thank you. I see one question, and then, well, that's a question to move on to the next speaker, in a sense that this question tackles, I think, Philip's talk too. He asks, did you get any useful recordings from field potentials in these areas? And Philip, I think you were going to talk about this, no?
That's correct. Yeah.
Okay. So let's go on with Philip de Vlo. Thank you.
Well, good evening, everybody. I've got just one case to show, and to be honest, it's a case which I didn't perform myself, but it was a case that was done in Toronto while I was a fellow there. And so you will see that there are some recordings which will probably answer the question that Tom just talked about. Let me see if this works. Okay, so this is a patient who actually came a couple of years earlier, before I was in Toronto, to the clinic for the first time. She's a 53-year-old female who had severe right hemi body pain, which started about 5 years after a stroke. And she described it as like having tooth pain all day. There was some triggers, as you see. And apart from the pain, she also had some right-sided weakness and motor aphasia, and even hypoesthesia for touch and vibration, and allodynia in her right hemi body. This was these were a few slices of her MRI scan, and so you could see a large MCA territory stroke, including the insula and the putamen, as you can see. And at that point, she hadn't tried lots of medications, so we, or at least the people who saw her in the clinic, proposed her to start on meds first, and she was only on oxycodone, and therefore she was offered the gabapentin trial and also ketamine infusion trial. And in the 2 consecutive years, she tried several medications, and gabapentin actually worked in the beginning with a reduction of pain score from 8 out of 10 until 4 out of 10. But then the pain recurred, and she came back to the clinic while I was there. And so at that point, we proposed DBS, targeting the left VC and the left PVG. This is sort of the standard way they do it in Toronto. To be honest, if she were to be living in Leuven, we might have offered RTMS first, RTMS of the motor cortex, to see if she's a good candidate for motor cortex stimulation. And I'm sure that most of you know, and that there are some studies showing a very high positive predictive value of RTMS of the motor cortex for the final result of motor cortex stimulation, but it wasn't offered in this particular patient. And so the common way of doing it in Toronto is that there are 2 electrodes implanted, one in VC and the other one in PVG. What is interesting is that later on we did an analysis of about 30 patients who were operated in Leuven and in Toronto, and it turned out that the patients who had both PVG and VC stimulation, all of these patients preferred VC stimulation over PVG stimulation. And so we don't do PVG stimulation generally in Leuven, but in Toronto they offer both, and they do it in the same procedure. I'm talking about VC, but a few of you might use other terms for it, and this is a little table showing the different nomenclatures. But what other people might call VPL or VPM is generally called VC in the Hassler nomenclature. And so the way they do it in Toronto is that they usually implant a single-sided VC and PVG at the same site, contralateral to the pain, obviously. And they also connect them, as Professor Aziz already showed, to percutaneous extension wires and do an external trial. In Toronto, they usually do it for only 1 week, after which they decide on internalization or not. This is a little more background on VC and PVG, and so these are all things that you probably know. But as you know, the main affective pathway, afferent pathway to VC is the medial lemniscus, whereas the afferents go to the somatosensory system, but also to the so-called pain matrix. And as Professor Aziz already said, that stimulation usually evokes paresthesia. So in a way, it's comparable to dorsal column stimulation. If you use tonic stimulation and dorsal column stimulation, you get the same kind of paresthesia. And if you can match that with a region of pain, it usually is a good predictor for the final result. Whereas PVG stimulation works in a completely different manner. And usually patients will describe a warmth, feeling of warmth or well-being or relaxation if you start stimulating in PVG. What is interesting is that you can tackle bilateral pain by unilateral PVG stimulation. If you look at the sensory thalamus in the different stereotactic atlases, on the left-hand side you can see the My atlas, on the right-hand side is the Schaltenbrand. You will see the different nomenclature, but we're talking about the ventral lateral part of the thalamus, just behind the VIM. And so I've indicated here what is shown in the atlases as the sensory thalamus, and you can see that it's just above what is abbreviated here as LM, the medial lemniscus. And so the medial lemniscus sort of brings the information to the sensory thalamus. This is the planning, and so you can see in red the electrodes, or the planning for the electrodes, which was aiming at the VC, whereas in blue you can see the electrode aiming for PVG. And this is the overlay of the atlas, as you can see. And so this is in an axial view, the same thing. Obviously, because of the stroke, it was not that easy to plan the trajectory, and so we opted for a transventricular approach. This is something that has been briefly touched upon already by Professor Aziz, but there is a somatotopy in VC, and this is a very old drawing from Hassler, and so you can see that opposite to the cortical organization of the S1 cortex, the leg is represented on the lateral side of the sensory thalamus, whereas the face and the arm are more medial to it. Obviously, this is a very old drawing, but in Leuven, we've been able to confirm this in a very old study, partly done by Professor Hebels and by Bart Nutin, where we actually recorded stimulation data in patients who were operated for pain, but also essential tremor patients in whom we targeted VIM, and were able to elicit paresthesia. And so you can see the same pattern. So in yellow, you can see that patients experienced leg paresthesia if you were stimulating about 15 to 18 millimeters from the midline, whereas arm and face paresthesias were only elicited if you were stimulating more medial. And so in general, we opt for about 10 millimeters from the midline if we are targeting the face, and then we go slightly lateral if we are aiming for the arm, and even more lateral if we're aiming for the leg. Again, this is the planning from the lateral side, and you can see the different subnuclei of the thalamus, and so VC is just behind VIM. As some of you might know, in Toronto, they are very interested in recordings, and so this is a bit answering one of the previous questions. So as you slowly slide in the microelectrodes, you can record from single cells. And what is interesting is that in VIM, you can see kinesthetic cells, and so upon passive movements by an examiner, those cells will respond, usually by firing and during the actual movement. And so this is typical for VIM cells, and you can also see that in VOP, but this is also typical for VIM cells. The lower you go and the more posterior you go, and the closer to VC you'll end up. And so what you tend to see is that in VIM you can see responses to touch, but usually these responses are only to deep touch. And so if you squeeze the muscles, if you squeeze the tendon bodies, you will see that these cells will respond with an increased firing rate. And this is typical for VIM, whereas in VC, you don't need to give those deep squeezing stimuli. You can just use light touch. And so this very superficial touch will suffice and to elicit firing in VC cells. And so that allows you to make a distinction between VIM and VC. I will show that in a second. And so this happens if you slowly go lower, and at the same time you go slightly more posterior. If you go too low, if you go beyond the ventral border of VC, you will end up in the medial lemniscus or in a transition area, which is sometimes called VCPC, and that is where the receptive fields will become much larger, And upon stimulation, you will generally see that there is actually hemi-body paresthesia at a much lower threshold as compared to the gray matter stimulation in VIM and VC. And so this allows you to define the ventral border of VIM relative to the medial lemniscus. I will show that in a sec. This is a drawing from the Scheltenbrand atlas, and so you can see the different subnuclei, VIM, VC, in the middle. I tend to find this quite difficult because in planning we usually see it in the opposite fashion, so we tend to swap this around. And so here you can see VOP, so this is motor thalamus, and VIM, which is a transition zone between motor and sensory thalamus, and then VC, which is the sensory thalamus, and this is a bit zoomed in. And then I've indicated here in green the motor thalamus, in orange the sensory thalamus. VCPC is just below, and the medial lemniscus are just below this. And then you've got this transition area between motor and sensory information, and that is where the tendon bodies send information to. And this is obviously very much well known in tremor, but it's also interesting here in these pain patients. What is the aim of the actual micro recording is to find the border between VIM and VC, and so this is sometimes called the sensory border. And so what you're looking for is this yellow line in the sensory border between VIM and VC, where deep stimuli are actually no longer necessary to elicit responses, and superficial stimuli will be sufficient. And as I explained, and the ventral border of VC can be found if you stimulate at the lower threshold and you elicit hemi-body paresthesia, then you know that you're probably in the medial lemniscus. And so this is a way to find the borders. I'm not sure if you will hear the sounds, so let me know if it's not the case, but this is stimulation in VC 1 millimeter above the target. Do you hear this?
Oh, we don't hear anything, no.
You don't hear anything, and so I'll just translate a little bit. So here we are testing superficial stimulation. There was no response, but with deep squeezing, there was a response. In this video, the surgeon is actually just touching very lightly. He will even use a clot in a few seconds, and you hear like a bursting pattern of the actual cells. And so we now at targets we are confirming that we are in VC, and so you hear like a brushing sound. You hear upon touch, and the fields and the projective fields are very small, and so it's only in the second digit that you hear this, but not in the rest of the finger. So it's a very small field. Now we are stimulating 2 millimeters below, and we are here in the medial lemniscus, and so the surgeon is asking, did you feel anything? Patient says, yes, I felt a very strong tingling sensation in my hemi-body, and this was only at 50 microamps, and so a very low threshold. And so this confirms that at 2 millimeters below target, we are already in the medial lemniscus, and so this all confirms that we are actually in VC. And so 2 millimeters below that, we are in the medial lemniscus, and 1 millimeter above, we were still in VIM. There are some interesting findings when it comes to these fields. If you compare patients without central post-stroke pain, if you compare them with patients who, for instance, undergo DBS for tremor, and so there are two major differences. One is that the receptive field does not necessarily match the projective field, and so if you stimulate, patients might feel paresthesias which are not in the same area as if you touch the skin and look for firing patterns. And so this is a very old study from Toronto where they did similar experiments in amputation patients, and so they were able to see that upon stimulation, patients felt paresthesia in the amputated limb, whereas if they stimulated and they were stimulating the stump and the same neurons and that were firing had different receptive fields and projective fields. And so this is different in patients who don't have chronic pain, and they will usually have the same receptive field and projective field. The bursting activity is also something quite different, and so in general in VC you have a quite low firing pattern, about 10 hertz is what is usually seen, but in patients with central post-stroke pain you tend to see this bursting pattern, and you will hear like a chopper of a helicopter. And this is a very characteristic finding in if you do recordings in VC patients. To come back to the actual patients, and so this is a summary of the cells we recorded. I will just show you another small video of the effect of stimulation. So now we are no longer recording, we are stimulating with the final electrode, and the video starts with a stimulation of the deepest contact. And what the patient tells is that she feels paresthesia, but it's only in the lower half of the body. And so I will skip the rest of the video, but if you stimulate at a higher contact, you will see that she will have stimulation in the hemi body where she felt the pain, and so eventually we are able to find a setting where she experiences the pain in the whole painful area. And so this is very similar to dorsal column stimulation. You're looking for a good match between the painful area and the area where you can elicit paresthesia. We also did VC stimulation, and so we are no longer looking. We also did VPL periventricular stimulation, and here we are no longer looking for a tingling sensation. What she felt is a sense of relaxation, a sense of warmth, a sense of well-being that she reported, and that also confirms that you're in the periventricular gray. So this is the final result. We ended up with 2 electrodes. During that week of external stimulation, we tested them both, but she preferred the sensory thalamus stimulation over the periventricular gray stimulation, and so only 1 electrode was connected to the battery. And in the long run, she had a good outcome. Although we also noticed, similar to the experience we have in Leuven, is that you need to reprogram these patients very often. And so it is not something like Parkinson's or tremor, where you start with a certain set of parameters and you only need to make small adaptations later on. Oftentimes these patients will come back and you will have to reprogram them completely. And there tends to be a kind of habituation or experience. And so these patients are generally well for 1 or 2 months, and then they tend to come back to the clinic, and you need to reprogram them completely. Sometimes if you lose the effect, if you do a stim holiday, the effect comes back, but it's a lot more time consuming as compared to for instance movement disorders. I've got a few more slides on central post-stroke pain, but I will skip them for the sake of time, if that's all right. I'm not sure if there's any questions.
Thank you, Philip. Well, I don't know if there's any questions. I have a few questions from my side. You showed this transventricular trajectory. Many functional neurosurgeons will be quite reluctant to put in electrodes through the ventricles. I don't know about Professor Aziz or Machado. I myself, I do it for epilepsy. So there we usually go for a transventricular route, but I'm not sure what other people would do in a stroke case. Would you go through the parenchyma or would you go through the ventricle?
I would avoid the ventricle much as I can.
Mm-hmm.
I do too.
Okay. One more question. You talk about sensory thalamus targeting. Does anybody have experience with targeting white matter bundles going to or from the thalamus? I'm talking about medial lemniscus or posterior limb of internal capsule. Is that an option? Or let's say a patient has a thalamic stroke and maybe VPM, VPL is damaged. Is there any strategy in these patients?
Well, if the sensory thalamus was damaged, you still have the periventricular gray quite often. And also, I've not had success with motor cortex stimulation, so I abandoned it about 20 years ago. But it's my perception that you can go more lateral into the internal capsule and implant somatotopically there and get paresthesia.
And if time permits, I agree with Professor Aziz. And if time permits,
for sure, sure. Go ahead, please.
Data later on the white fiber of the internal capsule.
I see that there's a few questions coming in. One is for thalamic pain syndrome. Presumably there is distortion in the thalamic anatomy. So how do you rely on the microelectrode recordings? That's one question.
I don't.
You don't? Okay.
So,
Why? How would you do? How would you go ahead with targeting? Because I can assume that you use ACPC based coordinates, but of course, if you have a distortion of the anatomy, is there any strategy? Would you look at the internal capsule, or are there any other?
yeah, the internal capsule is a very good landmark. And also if the third ventricle is very much distorted by the stroke, you can measure laterality if there's anything to stimulate by measuring it by the distance from the wall of the third ventricle.
We have a little bit of a different strategy in Cleveland. We actually use microelectrode recording to compensate for the distortion. We know there is distortion, and we use physiology to help us understand how it's distorted. Looking, for example, for the transition between the upper extremity and the face. That is a good landmark to use to understand how the distortion occurred medially, laterally, perhaps posteriorly. And once you have that, then you can also calculate or interpolate where to place your periventricular electrode, presuming that the distortion will be similar.
Is targeting using diffusion-based imaging, let's say DTI, useful in these cases, or is it?
Yes.
And in the post-stroke, DTI is always a little tricky. In the post-stroke scenario, it could get a little bit trickier because you have errors of co-registration between what you see in terms of connectivity and where it truly geometrically falls inside the stereotactic field.
Okay, thank you. Yeah, there is one very long question. I would ask everybody to put the question in the Q&A box. I see it in the chat box. I hope I can, well, I will read it. So, I used to have beautiful receptive fields and microstimulation, etc. This is a question for you, Philip. When you say larger areas, when deeper, do you mean per cell or groups of cells? Hand and face better defined anyway. What size electrode tip are you using? You mean you were using macroelectrode stimulation, question mark. Phase reversal of SEP was reported years ago. Have you tried this to define base of thalamus? It is a long
I'll try and answer a few of them. So one is that these larger areas, so the difference is basically if you move into the white matter of the medial lemniscus, if you stimulate in the white matter of the medial lemniscus, you will generally see that there is hemibody paresthesia as compared to the gray matter of the sensory thalamus. You will generally have smaller fields. So sometimes a finger or part of the face, but not generally the hemibody. So this allows you, together with the amplitude that is necessary. So for gray matter, you will see that you need a slightly higher amplitude as compared to the white matter of the medial lemniscus. And so the combination of these two, the size of the field and the amplitude necessary to evoke paresthesia, is I think a clue that will help you to define the ventral border of VC. Yeah. As a matter of fact, some patients here in Leuven have responded better to medial lemniscus stimulation as compared to VC stimulation. So in Toronto, they try to have all contacts only in the gray matter of the thalamus. But I think it might be an idea to put at least one contact at the border of the medial lemniscus and VC, because some patients tend to be happy with medial lemniscus stimulation. If you stimulate at the transition zone between the two, what is sometimes called VC-PC, you can sometimes have hemibody paresthesia at a very low threshold. So theoretically, it's not a bad target as well. And so I would not necessarily put all contacts above that ventral border. In terms of what electrode size tip do you use, and so here in Leuven we use the commercially available microelectrodes, but in Toronto they had this bespoke system where they had two electrodes at a very closely together, but this is something that they designed themselves and which is not commercially available. And so by using that system, they were able to really have single cell recordings rather than the LFPs that we usually record using commercially available electrodes. I am not sure about this, the phase reversal and the SEP. I think that more applies to motor cortex stimulation. So I've never seen that being used for definition of the base of the thalamus. But I mean I've no experience with that. So if there's anybody else who has experience with that, I'm happy to discuss that. But I can't really comment on that.
Yeah, maybe a final question. Then we go to the next speaker. There is one question. Do you have experience with CRPS? So treated with thalamic DBS. Any of you? Mostly in the arm in this case. Tipu, do you have experience with CRPS?
I have never done DBS for it. My inclination is to actually use pedal spinal cord stimulation leads with a retrograde approach coming down from the foramen magnum, sublaminar down to C2, that usually provides reasonable paresthesia coverage in the upper extremity. But some patients with CRPS actually do not feel the stimulation to be pleasant. The trial is very informative.
Okay, thank you, Professor Machado. I think we can go to your talk. Just small introduction. Professor Machado is a functional neurosurgeon working in Cleveland Clinic, who moved from Brazil in 2004, if I'm correct. And he will discuss the affective networks in pain and neurosurgery for pain.
We have only 3 minutes left, right?
You have plenty of time, no worries. We can extend this session as long as you want to. So please go ahead and just, if you have planned for 20 minutes, it's fine. Huh? So no, it's just, we wanted to try to keep it short, but if it takes 1 hour and a half, that's no problem.
Okay, I'll try to summarize to get to the gist of it and to follow.
Oh, but 15 to 20 minutes, fine. Thanks so much.
Okay. To follow on Professor Aziz's presentation before, we're asking these questions about what is it that we're trying to achieve in the first place. And the talk here is on DBS for pain, but specifically in modulating the affective sphere of chronic pain, not the amplitude of pain, but the perception of pain. Typically considered when many approaches have failed, right? All these patients that we consider for DBS have tried pretty much everything. And we did focus in the post-stroke population for several reasons. One of them is that the patients had the Dejerine-Roussy syndrome with hemi-body pain, using the other hemi-body as a potential control, and also that you have a clear-cut cause for why the patient has pain, which is relevant when you're treating a disorder that can be so subjective. If we think about goals, the question that was asked before, most of the strategies of brain neuromodulation aim at the sensory sphere of pain. What I am presenting in this slide here is from Ron Melzack and the evolution of his own thinking from the gate control theory of 1965, understanding pain at the segment level in the spinal cord, to his later theory called the neuromatrix, which really believes that pain is not a sensory experience, but rather an integration of sensory, emotional, and cognitive experiences into one. What we have seen so far throughout most of the presentation today is really on targeting the brain to produce analgesia, sensory sphere. The hypothesis that we explored here in Cleveland was whether we could modulate the affective sphere of pain independent of the sensory sphere. Is this possible in terms of neuromodulation? And in order to do so, we went after the anterior limb of the internal capsule, same area that we had previously explored with obsessive compulsive disorder, and with chronic depression. This, of course, a concept born out of Louvain itself. Years prior to that, we learned the technique. A clinical trial was advanced with other American centers in OCD and then depression. And this is a study that we did on the topography, the physiological topography of the anterior limb of the internal capsule. What is it that you learn when you stimulate this area? The depth electrode there, the bottom electrode, is really deep to the anterior limb of the internal capsule inside the ventral striatum itself. The clinical trial was the first randomized control trial in DBS for pain. We took 10 patients with post-stroke pain syndrome, and they had failed, usual medical management. And this is the design of the study. All patients had baseline assessment. All patients were implanted the same way. All patients underwent programming, single-blinded programming. The person doing the programming knew what was going on. The patient was unaware of the settings. And then we randomized patients to on DBS or off DBS. They stayed in that state, either on or off, for 3 months. And then they were crossed over. Question here around carryover effects is very pertinent. Then they crossed over. Those that were on went to off. Those that were off went to on for another 3 months. And this is double-blinded, randomized control phase. We really evaluated their outcome at the 3rd month, before randomization and before the end of the randomized phase, to try to discount possible effects related to carryover, which absolutely is a risk in a study like this. And then they had open label follow-up for 1.5 years. If you want to look at the results in more depth, it's in the Annals of Neurology. And I highlight here seizures as a safety concern, exceedingly rare when we do surgery for Parkinson's disease or tremor. We had 2 out of the 10 patients present a symptomatic seizure the day after, unrelated to stimulation, just from insertion. And here are the results. We are aiming at the affective sphere of pain. So we're using scales of depression to evaluate the outcomes of the patient. And regardless where you put the cutoff for response, 30% better, 40% better, or 50% better, there is a difference between the group between assessing the patients when they were on. That doesn't matter if they were on first or on after the crossover. If you compare the on time to the off time of the patients, there was a significant difference regardless of the cutoff. If we look at the other depression inventory, this is the PEG depression, another way to measure the same thing. The results actually quite similar, not very different. If you look at quality of life, there is a substantial difference in quality of life in the patients, and the blind was maintained throughout. These patients were constantly asked whether they had the stimulation on or off, and they did not come better than chance at knowing. So this is not the magnitude of stimulation only. There was a significant difference in quality of life. When we look at disability, a different question, no difference. Interpretation here, how come quality of life is better, but disability is not? Possibly because they are hemiparetic. That's my interpretation. It prevents them from getting less disabled. The hemiparesis remains. And the question was asked, what about the amplitude of pain? There was no change in the visual analog scale reporting. The effect of stimulation in the anterior limb of the internal capsule was specific to the affective sphere without influencing the amplitude of pain. Therefore, the improvement in quality of life can only be attributed to the affective sphere, not to the change in the amount of pain. These are some studies. I'm just going to leave this slide here. If anyone wants to look at the magnetoencephalographic correlates of the results. This is a series of studies that we did to electrophysiologically characterize what was happening during the stimulation phase and prior to the stimulation phase. Just in the interest of time, I will skip the electrophysiology and I'll show the fMRI. Patients underwent fMRI during the blinded phase. We wanted to know what was activating versus what was not activating. And this first slide shows you two groups of patients: normal controls, people without chronic pain, and the patients with chronic post-stroke pain syndrome. And you see how different the pattern of activation is in response to a nociceptive stimulus. So this is fMRI, it's in response to a stimulus, and the stimulus here is a nociceptive stimulus to the affected side, to the side with pain. Look at the orbitofrontal cortex, look at the insula and the thalami, how active it is. Now, let's look at a different comparison here. Now, these are all patients with stroke. We no longer have the healthy controls in the slide, comparing off with on. And off DBS is on the top of the screen, on DBS is on the bottom. Look how much it attenuated the amount of activation in the insula. Look at how much it attenuated even in the thalami. Only the posterior thalamus is involved. You don't have that much activation of the anterior and mesiothalamic structures. It's also less bilateral in nature. For my summary here, this is a first study. It's a small study, but it's sham controlled. We see a substantial modulation of the affective sphere without modulating the amplitude of pain. The sensory sphere was not touched. And there were imaging correlates that corroborate the finding in terms of the areas of the cerebral cortex and diencephalon that were activated in response to pain, comparing DBS off with DBS on. Just failed in the beginning to thank the opportunity from the European Society for the very kind invitation. I think it's my first opportunity to present, and I wish I were there in person.
Thank you, Professor Machado. Yeah, very interesting talk, and also, yeah, a target that not many people have used for pain, I assume. Can you comment on this target if you compare it, well, for psychiatric disorders versus pain? Is there any difference in let's say, settings? Because I know Bart Nutin, well, used this target, of course, for OCD, and he usually uses high voltages. I don't know what your experience is when you compare these settings in pain patients.
Settings were not very different. The amplitudes here were high. Frequency was high frequency as well. Pulse width was a long pulse width. Not very different. What really struck me when I looked at this, our center participated in the depression study, right? Reclaim study already published. No differences were noted in patients with depression comparing on and off, randomized controlled trial, no differences. But when we enrolled patients with pain, significant differences in the same depression inventories that we had used in the depression study. There was no effect in depression for depression. There was a substantial improvement in depression secondary to pain. Different disorder, right? One is a secondary depression, one is a primary depression. Very different results.
Any pathophysiological explanation from your side or ideas about this?
Ideas, I have to now speculate, right? I have no data to back up anything. To me, the most important personal learning out of the Reclaim study, the depression study, is that improving mood acutely has nothing to do with improving depression chronically. Acute modulation of mood does not amount to chronic resolution of depression. In the pain population, chronic modulation of the affective networks amount to a chronic improvement in quality of life.
And for your study, yeah, you say I'm targeting affective symptoms, let's say. So I assume that you do the MADRS score before surgery. Is there any selection criteria or anything to take into account? Let's assume there's a patient with a post-stroke pain coming to your office. Is there like specific targets you would propose for specific patients?
That's still unresolved, right? We did this study to answer a question. Now, in the clinical use, we debate around utilizing the combined targeting that was proposed by Professor Aziz, shown here today by Philip as well. We consider that for our patients on a case-by-case scenario, but often the areas that we want to target are damaged in a thalamic stroke. And this becomes a viable alternative to managing those patients because these networks are preserved.
Olaf, please go ahead.
Yes, Professor Machado, did you see an age-dependent effect?
Age dependency, we didn't, but also the age range was limited. Not by intent. We were willing to enroll anyone between 18 years and 75, but the majority of the patients were in their 50s. So we don't have a range to be able to know if there is an age dependence.
Okay, thank you.
There's one more question. It's a personal question, I guess. What do you think about DACC, so anterior cingulate stimulation, DBS for pain? Do you use it in Cleveland? Is it something?
We never done it. And one of the concerns that we had in the choice of not using it was the concern of epileptogenesis, the concern that chronic stimulation of the cingulate could have an epileptogenic effect, and we shied away from it. In our study, we had symptomatic seizures related to the insertion, but no one had a seizure related to stimulation.
Yeah, no idea. Do you have any idea how these seizures, is it like a kindling mechanism of the ACC? Because of course I've heard about amygdala kindling. We have seen seizures in motor cortex patients, but that's only when you program or reprogram patients, but not during chronic motor cortex stimulation. So it's a bit remarkable that this chronic ACC stimulation can provoke seizures. We don't have any experience with this target, but
I think it is kindling.
Professor Aziz, sorry?
I think it is a form of kindling because we're taking patients who've never had seizures and they basically become epileptic until we change the parameters of stimulation.
Because you aim to, of course, stimulate the cingulum bundle, let's say, because you're in the white matter,
Yeah.
but at these voltages, probably you're also, stimulating cortical. Yeah.
It's quite a significant stimulation, 5 volts.
Yeah. So I can imagine that you're also stimulating the anterior cingulate cortex, and that is like I didn't know it was so prone to kindling because all the kindling models are usually mesial temporal, amygdala. Well, it's remarkable. Does somebody have experience with insular stimulation, insular DBS?
We only have one case in Oxford. Sorry. We have a patient with a high cervical injury and total body pain. We tried sensory thalamus paraventricular gray. We even tried cingulate. And then my colleague Alex Green implanted his insula based on fMRI. And the patient's self-reported VAS scores dropped from 9 or 10 to 1 or 2.
That's an impressive result.
So he hasn't published it yet, but it's quite dramatic.
And then did he implant the contralateral insula, or is it like the fMRI was activating?
He implanted
both
the
insulas.
area that was most active on fMRI.
Okay.
So it's another alternative as we explore the neural matrix, as Machado described Patrick Meltzak's description.
Any more questions from the audience? Remarks? Then I want to thank everyone, especially speakers, for sharing their insights. It was really enjoyable, at least for me. Professor Machado, Professor Aziz, thanks for sharing this. Philippe, also thanks for your presentation. I want to thank everybody for joining this session, and I hope to see you next time in our second webinar.
Mhm.
Thank you.
Well, thanks for having us. Thank you. Bye.
Thank you very much. It's
Have a
an
nice
absolute
day.
pleasure.
Thank you very much.